Good morning, everyone. Today we welcome you all for Complex Case Conclave this Sunday morning. We have two experts, very good experts today, Dr. Ajit Menon and Dr. Ravi Kalra with us. So I'll just give introduction about these two. Everybody knows them actually. Dr. Ajit Menon is a senior interventional cardiologist from Mumbai. He's attached to Lilavati, Bridge Candy, and HN Reliance Hospital. He has experience more than 25 years. He's a proctor for complex cases like retinal bifurcations, multivessel PCI, CTOs, imaging guiding PCI, FFR, RFR, and rotational axectomy. He has participated in numerous national and international conferences as his faculty. Also, is a live case operator, and he has various abstracts and publications across many journals. Regarding Dr. Ravi Kalra, he has more than 25 years experience in cardiology with teaching experience more than 17 years. He has served in INHS Ashwini Mumbai more than 18 years. He is retired from Indian Navy as director and commandant of Armed Forces Medical College and currently HOD Cardiology Department of Bharati Vidyapit Medical College, Pune. He started his cardiology career with humble stethoscope and is now hands-on with modern technology like tower and coronary imaging. The program will be like this. First, I'll give you a 4 to 5 minutes talk on approach to complex cardiac intervention. It will be just brief 4 or 5 slides talk, followed by cases by our panelists. We have panelists Dr. Sunil Mani, Dr. Amit Sangvi, Dr. Ashish Agrawal, Dr. Chitran Bambure, and Dr. Tanay Padgaon. So first thing is my brief talk. So I'll start with my talk and then we'll go to the cases. Approach to complex interventions. What is complex intervention? It can be because of complex anatomy, coronary anatomy, location, and complexity of the lesion. Maybe because of comorbid conditions. It may be because of concomitant cardiac diseases like structural valvular diseases associated LV dysfunction or decompensated heart failure. So, like these are the spectrum for coronary anatomy is what we encounter as a complex case: multivessel disease, unprotected left main coronary artery disease, fibrocalcific and undilatable lesions, chronic total occlusions, and degenerated saphenous venous grafts, thrombotic lesions, bifurcation diseases. So, basically, in a brief approach, appropriate patient selection, knowing the extent of CAD, reading angiogram properly prior to the approach to the case, knowing ejection fraction, viability, hemodynamic status, and comorbid conditions. Now, hard trim approach is always a preferable approach in such cases. So, what is the toolbox for such cases? The experienced and skilled interventional cardiologist is a must. Hardware, you should have sheets, guides of different sizes, shapes, long sheets, wires, microcatheter, guide extensions, snares, cutting balloon, OPN, rota, IVL, imaging, stain grafts, coils, glues, gel foams to take care of your complications. Uh, I'll just briefly go through next two slides regarding some tips in complex intervention, and then we will go to the case presentations. Reading angiogram and planning strategy with anticipated requirement of hardware makes 60% of the job easy in complex interventions. Choose and handle your guide rightly makes job easy. Nowadays hardware is very easy to handle. Very fantastic hardware is available. Low profile balloons are available. So the thing is most important is handling your guide right. Guide alignment underrated but smoothens the procedure. Mental rehearsing of all steps prior to any bifurcation makes things easy and helps to avoid silly mistakes. Correcting wire biases with guide movement or releasing on tension wire helps in passage of device easy many times. Anchor balloon very helpful in salvages. Never forget kidney and groin. Keep low threshold for rota in calcific lesions. Planned rota less complicated than rescue rota. Elective ventilation in borderline cases always helps. It's always a must in labs. Early and elective IVP also helpful rather than after crash. With experience, learn to anticipate things. Good assistant and friendly surgeon are always helpful. Keep always a plan B ready. Safety most important, so don't venture if there is lack of hardware or support. So with this my brief presentation, we'll go to the first case by Dr. Ashish Agrawal. Ashish is an interventional cardiologist. He practices in Mulund and he attached to various hospitals over there. So Ashish, over to you.
Yes, sir. I will start sharing the screen.
We'll try to keep it little interactive, so we might stop in between and ask questions to experts. Okay.
Sure.
I hope my screen is visible.
Not yet.
Yeah.
Yeah.
Yeah. Good morning, all respected expert panel, moderator, and dear colleagues. I will be presenting a case of in-stents wrist stenosis. So this was a case in which the wrist stenosis was in a segment of vessel between two stents. So it was not within the stent, but rather between two stents. This was done by me and my colleague, Dr. Prashant Kharche, last month. The story is that this is a 74-year-old gentleman. He was hypertensive with borderline creatinine. He had an non. Sorry.
Yeah, you can go ahead. You can go ahead.
Yeah, he had an acute coronary syndrome in January of this year, probably an STEMI event, for which he underwent angioplasty to RCA with two stents. Now he came to the OPD with 1 week history of new onset angina. Initial few days he ignored because of lockdown and all, but later on the angina became too much. Even routine household activities were causing typical chest pain. His ECG, echo, and troponin levels were within normal limit. This is his angiogram. Left side was fairly okay. There was some diffuse disease in the OM in the LAD. No critical lesion. In this shoot, we can appreciate the calcification of the RCA and presence of stents in the RCA. This was his RCA shoot. So we can see stents in the proximal portion with calcification around it, and small stent even distal to the lesion, which is not very clearly appreciated. But looking at this RCA, we thought probably not so tough job. We can probably get away with one stent with good pre-dilatation, and maybe in COVID times we should try to finish off the procedure early. The Tiger catheter was also sitting nicely, so we thought probably a simple guiding will also help. But then my friend Dr. Prashant, he did the smart thing. He called the previous operator. So here we can appreciate the calcification and the under-expanded portion of the stent. Probably there is a gap between the two stents. So the operator said it was a long case. There was difficulty in delivering the hardware, delivering the stent. He initially planned for one stent, but later on he has to use two short stents, 318 and 38, in an apparently overlapping fashion. After that, the patient remained okay for 6 months and now came with symptoms. He was on aspirin and ticagrelor. So with this history, and the angio finding, we anticipated problems. We thought that
Ashish,
probably will require a lot of support.
Ashish,
Yes, sir.
do you have a previous
Yes,
angioplasty CD?
Previous CD was not available, sir. Unfortunately, we had a word with the operator, but the previous CD was not available.
But the stents are obviously not overlapping in the present angio.
Yes, sir. But he said that he actually did it in an overlapping fashion.
Okay.
So previous CD was unfortunately not available with us, but he was very clear that there was a lot of difficulty in delivering the stents. So we anticipated the problem. We thought we'll go with a femoral route with a good support guide. We'll keep a support guide wire also handy, and we'll require guide extension. And we thought of imaging. Fortunately, OCT was available with us. Of course, we have to plan it the next day of angio. And we thought of debulking strategy with the help of IVL balloons. We thought that we will probably avoid rota in view of previous stents. When we started with AL1 guide, it was sitting okay. There was good support, not absolutely coaxial, but after wire, we started with a plain run through Renato wire. There was no significant difficulty in crossing with the wire. After that, the guide became more aligned. Then we dilated first with 1.5 by 12 mini trach balloon. It crossed the lesion with minimum difficulty. There was rupture of the balloon after dilatation at the lesion site. This is a stent boost which we took with the help of a second balloon, 2.5 balloon. It was clearly showing some gap between the two stents and significantly probably the under-expanded portion of the proximal stent. With 2.5 10 sufficiency balloon, we dilated the lesion again, the proximal portion. There was significant recoil. After this dilatation, we tried passing the OCT catheter, but it was not going in. And then we took a larger balloon, 3O balloon. This balloon was also facing problem to cross the lesion. So as here you see, second step was we took a buddy wire with Grand Slam. Even with that, there was difficulty in crossing the balloon. As we can see, the guide was backing up. The new balloon used to go across the lesion, but once dilated and we are a little back, then it was very difficult to recross the lesion with the balloon. So here, after this 3O balloon dilatation, we dilated the lesion.
But balloon is fully expanded. There is no waste on balloon, right?
Yes. And then there was no waste as such. So we were happy. We thought that now the OCT must go. And then we also dilated the proximal portion. Here a problem happened. Basically, after this dilatation near the ostium and with some guide sucking in, there was sudden bradycardia. Probably there was a spasm of the RC after this event, and patient went into progressive bradycardia. One operator has to stop and start CPR. The anesthetist was there at the head end. He gave atropine, and other operators started putting the temporary pacing wire. We already had venous sheath in place, fortunately. So with the removal of the balloon, one wire came out, the other wire remained, and we were able to salvage the situation. After that, there was some tachycardia, but patient settled down without intubation. And after that, we had already done a 3O balloon dilatation. So we thought now we will try with the OCT. But again, even after 3O dilatation, the OCT was not easily going. It was getting stuck at that same lesion site where we had actually had a very good balloon dilatation. So now we thought probably we'll start with the GuideZilla catheter, because even after 3O dilatation, nothing is going. And we thought probably we'll not go after imaging, but we will first try with the debulking with the help of IVL. Even though the IVL balloon was bulky, the GuideZilla really helped the balloon to go at least up to the lesion part. It was not crossing the lesion. Obviously, we didn't expect it to cross the lesion, but we thought we'll probably give some pulses here and make some debulking in the proximal portion, and then we'll try deep intubation of the guide liner. So after a few pulses here, we then were able to pass the guide liner little deep, and with the help of guide liner, then balloon now crossed the lesion. Here then we delivered ample pulses, around 40 to 50 pulses with divide 12 IVL we delivered.
Ashish, can you stop here? Yeah. I want to ask a few questions to the expert panel. Dr. Menon, the initial first balloon was fully expanded over here. So is there actually a role of IVL over here? Or otherwise he could have done is put a guide liner inside and do a OCT and then decide whether IVL balloon is needed or not?
Okay, see, 2-3 things. One is if you see the initial angiogram, the uptake of the RCA is a little upward uptake. It's a little difficult uptake of the RCA. So that itself would have given an idea that any of the guidings that you use, first, the most important thing that you would require is a good guiding support. Second, like you said, the balloon crossed the lesion, it inflated there, but it was you could not recross the lesion with an inflated balloon, with an already inflated or pre-inflated balloon, which means that there is definitely some calcium there. There's something which is obstructing the free movement. It could be a calcium spicule, it could be a calcium blob at that point. An OCT would have helped, but you couldn't get an OCT catheter also down. So I fully agree with this decision to take an IVL down there, because it does give you a better lumen. I mean, it does break the calcium up a little bit, gives you a better lumen diameter, get a better lumen access for any other device to get in. There are situations where even if you dilate with a balloon, your balloon looks expanded, but if there is a calcium spicule which is sitting in that, or a calcified arc of the vessel, that's going to give a wire bias, and it's never going to let a device get in.
Yeah,
And you
if
will
I
always
may add to that,
you will end up with an underexpanded stent.
Yeah, Dr. Kalra.
if I may add to that, the moment you find that an already inflated balloon is not recrossing, that's a harbinger of forthcoming crisis. That means there is something. What Dr. Menon said, I fully agree. There is something there which you cannot see in this view. Maybe a change of view would have helped. I don't know if there was another view taken. And
Yes,
Dr. Menon, I wanted to ask you: is it absolutely forbidden to use a rota within stints? I
No,
think
no,
I
not
don't
at
think
all,
so.
not at all.
because
See,
rota would have really helped in this case.
yeah,
I feel.
I was coming to that. See, when you see a lesion like this, and especially at a bend in the vessel,
Yeah.
and you feel it is calcific, it's always better to go in with, I mean, go in with a rota up front.
The,
Um,
Yeah.
so
the problem,
it might clear the situation.
the
Ashish, one
problem,
question I have for you: what made
yeah.
you choose a Amplat's guiding in this
uh,
situation, and not a regular JR4?
Yeah.
because of the discussion with the previous operator, sir, it was it was very clear that he used JR and there was a lot of difficulty in support. So
See,
that was the
secondly,
reason we went upfront with
he had this guideliner with him, so he could have put OCT
Put the
catheter prior
OCT catheter. So,
with
Shataru, I agree
guideliner.
with that. What you're saying is if you get the OCT catheter, you would see better and you would decide the strategy accordingly. And the other problem with rota in
uh,
a bend and stent is that if you do a rota, the stuck burr is a possibility in this situation. So you should always keep in mind that before you take in rota, which I agree with Ashish that that's why he was worried to go ahead upfront rota. If you had seen with the OCT, that would definitely understand what is this and
See, so Sunil, what you
yes, sir.
see as a bend, in the vessel on an
yeah,
angiogram may
So
not be actually a bend in the vessel. It is the alignment
yeah,
of the plug which makes it look like a bend.
sure.
So it will be a straight vessel. Now, after you stent this vessel, you will see the vessel will be relatively straight in its.
But we don't do the stent
So
the expansion and all. And say when you have the rota, do you think you would with you have more experience on rota? So do you have any experience where the burr gets stuck? Because that's what.
no, I think it's a discrete lesion. I think
in this situation, I wouldn't expect the burr to get stuck
yeah.
because if you go slow, the burr should not get stuck.
Yeah, it should not.
So secondly, if you see your balloons were getting obstructed, even your OCT's catheter was getting obstructed in the proximal segment where the previous stent was there, not at the lesion site. Actually, that might be because of wire bias and guide alignment. Sometimes the things are obstructed because of that. Yeah, you can go ahead now.
So points very well taken, sir. The thing we actually tried with OCT 2 times before this picture. We were little reluctant this time because he already had one event in the interim period. So we thought probably we will first better prepare the lesion and then think about the imaging. That was one reason for not doing OCT through the Guidezilla. And for rota, sir, we reviewed some articles. They show a lot of heat generation with previous stents and probably little poorer long-term outcomes. But of course, that is one debulking thing which we definitely thought of, but because of the concerns, we avoided that. So here, after the IVL balloon dilatation, here is the second view, RAO view. Here also the balloon is looking well dilated. There is some vest we can see here, which was probably the site of lesion. After that, we were able to do the OCT. Here, the catheter went in smoothly after this IVL dilatation. Of course, through the Guidezilla, but it went in quite smoothly. So this is the OCT picture. It was showing distal vessel reference diameter was around 2.7, 2.6, 2.7. The proximal stent was properly sized. It was a 3O stent. It was very nicely expanded, as we can see. This is, of course, after all the balloon dilatations, but it was looking adequately sized. And here came the problem portion. Sorry, I just missed it.
Let it run. Yeah.
Okay. So here was the problem portion with calcium, and this was the proximal stem.
Any comments, sir, from you on OCT?
Shall I run it again, sir?
Yeah, just run it again.
So you tell me to pause if you want me to.
Yeah. Okay, just pause it. Just pause it. Yeah. See, in this, you can see that there is a significant there's no stent in this segment, and there's significant amount of calcium which is there all around.
It's almost 360 degrees calcium.
Yeah, and it's quite a thick bed of calcium. And I think you can see the cut. This is after the IVL, right? So you can see a significant amount of fractures on the calcium. Go a little ahead.
The stent is not expanded here.
There's no stent.
Yeah. No, go ahead. You're going backwards.
Here, are you within the stent?
This is a little fracture.
So it is between the two stents.
Between the two stents. Yeah. So this is what probably prevented the previous operator from overlapping this segment.
Yeah, probably there was a geographical miss. The stent would not have gotten to the other stent.
I think there is a stent over here. There are two gaps which are seen actually. One gap is here and one gap is here. So whether there was a stent fracture.
Go a little ahead. Go a little ahead. Go ahead.
Here actually stent is there, but there is neointimal hyperplasia, which is.
Go ahead.
Now this area is without. It's a small area without a stent. A very small area in between the two stents, which is a narrow miss.
Yeah. So the problem is between the distal end of the proximal stent and the proximal end of the distal stent.
Yeah. And distal stent proximal part, there is a fracture also. Actually, you can see a fracture also. Yeah, maybe post IVL. Little height. Okay. Yeah, here the stent is not seen actually, and then again stent is seen. Then again stent is not seen. Okay, you can go ahead.
And there was, some calcium spur also we can appreciate, sir, at the tightest portion.
Yes, you have significant calcium there.
Yeah. So this between 6 to 9 o'clock, it was probably that bend which was appearing like a spur, which was preventing everything from going in.
Yeah.
So after this, we because the area was still quite narrow, even though there were calcium cracks, we again passed the IVL balloon and delivered the remaining pulses at the lesion site. Then we did dilatation with 3ONC balloon at high pressures, around 20 atmosphere pressure. This was the picture pre-stenting. Here the lesion was looking nicely expanded.
One sec, Ashish. Do you need to post dilate even after IVL balloon, Dr. Menon or Dr. Kalra?
IVL, I have very limited experience. Ajit.
IVL normally you don't require to post dilate because what you need, what you're getting with an IVL is preparation of the bed and improving the compliance of the bed by cracking the calcium. So you're not going to gain anything more by going on a high pressure with another balloon.
Yeah, because it goes up to 60 atmosphere. So already you have dilated. So I don't think there is a role of any post dilatation with the second balloon. Yeah.
And the IVL is a compliant balloon. It's a little compliant balloon. It's not a non-compliant. So you already achieved a larger diameter. You've already given up to 50 atmospheres of pressure pulses with it. So you don't require to go with a high pressure balloon. You won't gain anything much.
Okay.
Okay, sir.
Go ahead, Ashish.
Go ahead.
Then we decided to put around a 3x24 expedition stand. Our thinking was that we'll first cover the problem portion first, the portion between the two stands, and the IVL approximately in the same length we delivered the IVL. Distally, the stent was well expanded. So we thought even if we finish just at the site of the stent, it should be enough. And proximally, we thought we will review once we have put this 24 stent. Then after post dilatation, we will review the proximal vessel. Because there was actually the guiding was going in quite often, and we thought probably we might have to put another stent proximally. So this was the stent positioning. We went at this was 3x24 Zion's expedition stent. Went at 60 atmosphere pressure, and then we did post dilatation with 3x10 NC balloon. At this portion, we went slowly up to 26 atmosphere. Then we took the balloon proximally, and in the proximal portion also we did some gentle balloon dilatation at nominal pressure in the proximal portion of the stent.
Is it advisable to go such a high pressure post IVL?
I mean, there's no issue in going up. I see we have already done an OCT, and you don't have any very deep dissections or cracks going all the way into the beyond the media. If you see on an OCT that you have cracks or dissections going into the beyond the media, then you need to be a little careful.
I think it will be very difficult to visualize on OCT.
No, I don't have the film with me right now, but Amal will have it. We have a case where in the left main we can actually see the because the calcium was on one side, the balloon dissected and went almost beyond the media on one side.
Yeah, okay. That India Live case.
Yeah, exactly. Yes.
Okay, Ashish, go ahead.
Yeah, so this is this is the OCT post angioplasty. We try to take the guiding catheter as back as we can so that we can see the proximal portion also. There the OCT picture, it was showing adequately expanded stent. Even after so many dilatation at the site of that calcium spur, the human area was around 3.64 to 3.7 millimeter square.
Here,
apart from that, rest.
So, yes, Dr. Kala, you have a comment?
No, I was saying here, where he has stopped just now, there is still a waste. There is that same portion which caused all the problems, isn't it?
Yeah, yes. MSC of 3.63 is less actually. It again points to a further risk of restenosis, right?
Yeah, restenosis and even stent thrombosis.
Yes. So, did you cover whole the proximal stent even with a new stent?
No, sir. So we actually thought about doing something like an OPN balloon here, but then there was this calcific spur, and we had already gone to 26 atmosphere with the NC. So we probably thought we will stop at this moment. I mean, that is probably for expert panel to answer whether we should have gone with OPN balloon here.
There is a comment from the viewers is sometimes you may have to use an ultra high pressure balloon like OPN to dilate the lesion. What they are saying is you can combine IVL with OPN. Any experience
right.
about that?
Right. And in calcific spurs which are eccentric, whether it is really advisable, that is what we actually wanted to know.
Yeah, yes. Just
see we don't have too much of data on using an OPN balloon after a IVL, but if after an IVL, if you still see a waste or you don't get a good missing on your OCT or on angiographic imaging, it is fair enough to use an OPN balloon to try and dilate the lesion. So again, my contention would be that with OPN also you're generating pressures of almost 50 atmospheres.
Yes.
So, Dr. Menon, I have a question. Say, in case we didn't have the IVL, Ashish didn't have the IVL, and you had to do this with Rota, how would your strategy would be? do the rota with what size burr, and then what later after that?
Yeah, Sunil, one sec. So basically the comments basically two things. One is whether like OPM and IVL almost have a similar mechanism of high pressure dilation. Whether rota and orbital arthrectomy have a different mechanism of cutting the lesion. So whether it's better to combine rota with IVL in such situations rather than IVL plus OPM.
Yeah, rota tripsy could be.
I would agree with you, Shantanu, that here is a situation where probably we would have gone upfront with a rota. And if then used then you can always use either an OPN balloon or an IVL. You don't have to, and to get a good bed before the stent. If you cannot get a good opening with a normal NC balloon. I'm not sure. I mean, it's a good idea to use a IVL and an OPN balloon, but the only concern is with the IVL, you're already causing enough cracks. So you're a little worried about going very high pressure with another balloon on the same area. We don't know the risk of perforation in these situations. If you weaken the wall somewhere, you may suddenly just cause a burst hole there.
There is one more question. Can we use rota in 6-month-old stent? Basically.
Yes, you can. Definitely, you can.
We have already discussed.
Okay, go ahead, Ashish. Finish off. Yeah.
So after that, we avoided that dilatation. We took out the guiding. We waited for 10 minutes, and then we took shoots with the diagnostic JR to see the proximal vessel as well as the stent. So these were the pictures.
Ashish, I must commend you on the. I must commend you on the very. I mean, you have used the Amplat's guiding very well, but except for the one situation where it jumped in and you caused a brady and almost a cardiac arrest. But otherwise, the proximal segment has remained pristine clean. That's one thing you need to be always concerned about when using an Amplat's guiding.
Yes, sir.
The other problem with the Amplat's guiding is your manipulation of the guiding becomes very limited.
Yes, sir. So here we accepted this result, stopped the procedure. We thought there are like lot of learning points from this case. We went in with 6 French guiding. We thought probably 7 French would have given even a better support. We thought we probably would have used guideliner little upfront when the initial balloon was not going with guidezilla support. Probably that was the time when we would have immediately brought in the guideliner. And also at the hindsight, we think probably would have put the TPI initially, balloon tube TPI, because it was a difficult RCA. So we should have anticipated that problem. So again, yes, there is risk of restenosis. High pressure OPN we already discussed. Rota, I think we have already discussed. So I will probably invite comments from
we can have a little bit discussion on IVL here. So how many pulses, like there are some questions, how many pulses can be given maximum in a case we don't have expansion after 80 pulses?
I mean, the catheter can take only up to 80 pulses, so nothing, you have to change the balloon, change the thing again. But my guess is that if it doesn't open in those 80 pulses, you need to change your strategy.
Yeah. Sir, I'll ask you one question. If you have to do this case, now you know the whole history and everything, how would you done basically this case?
I would have, at least I would have chosen rota as the first, so for various reasons, mainly familiarity.
Okay.
Yeah, because calcium rota, as far as we're concerned. These are all new technologies, of course, we can combine, we can think of various things, but rota is the gold standard for me.
So when we plan such a lesion, what you said, Shantanu, the most important thing is guiding support. You need to see what catheter can give you a guiding support, and especially in difficult lesions like this, you need to be able to manipulate the catheter. Of course, you have the guideliner now, so it becomes much more easier. So probably I would have gone with a 7 French regular JR4 guiding, gone with a rota up front, which means that we would have put a temporary pacemaker wire. Even otherwise, if we are doing a rota on the right coronary artery, a temporary pacemaker is a mandatory for us. Rotablate the lesion, use a OCT to look at the reason for the restenosis, use a high pressure balloon, upgrade to an OPN balloon if necessary. If you have IVL, then it is an added advantage if cost is not a concern. And then finish the procedure with the stent. So guideliner would definitely be a part of the armamentarium, because we know that when you have a near miss between two stents, even if one of the stent struts is not well deployed, is not well enclosed, or is not encapsulated, you may end up with a difficulty getting any device in, because that obstructs the lumen.
One comment, Ashish has done an extremely good case, and I feel that, see, if your balloon has crossed, then I think going back to rota versus doing more of IVL, you have given 80 pulses, give more. That could have been one other option that you had. One more balloon, and possibly, and then checking on the OCT and deciding how much area that you have achieved, and then take a final call on the stenting.
Yeah. Nice case, Ashish. We'll go to the next case now. Yeah. Well done, John. Yeah.
Very well salvaged. Very well.
For all the discussion, I think a good job done at the end. I don't. We can only contemplate, and we can just guess that maybe rota would have been better. But very good result finally.
One comment I want to add, sir. It was basically the OCT guy was also very sure that there is a big spur there, which is probably causing all the problems. So if spur is there, this OPN balloon, rota or IVL, I don't know if we have anything related to capture an eccentric spur.
Yeah, eccentric spur only orbital asymptomy works, which is not.
Ashish, one more learning from this is that you did a great job in terms of getting the patient out. And I mean, you saw that there was a little residual left behind, but in spite of using high pressure balloons, in spite of IVL, and you have used and the segment is stented. Remember that better is always the enemy of good. Sometimes you need to know when to retreat.
Yeah.
Right. Well taken, sir. Point well taken. Thank you very much.
What are the chances of restenosis you have given to your patient, Ashish?
Yes.
Okay. We'll go to the next case by Dr. Amit Sanghvi. Amit is a senior interventional cardiologist attached to Godrej Hospital, and he practices in Goregaon. He is a extremely well versed interventional cardiologist. Does a lot of complex procedures. So Amit, mic over to you.
Thank you so much. I'll just share my screen. Can you see my slides?
No, not yet. Okay. You can click on that hide. Yeah.
Yes. Just a minute. Yeah. So is this are the slides seen now? Is it clear?
Yeah.
Can I go ahead? Okay.
Yes.
Okay. Thank you so much. So this is a case of a multivessel PCI which I had done about 3 months back. So this patient was a 70-year-old gentleman who was hypertensive since more than 10 years, was dyslipidemic. The problem is he had one episode of acute pulmonary thromboembolism secondary to a DVT about 6 years back. And at that time, he was admitted in a peripheral hospital. He was thrombolized with urokinase and then put on acetone as long-term therapy. He still had mild to moderate residual pulmonary hypertension since then. And he had very minimal exertional dyspnea persisting even after this acute episode. So he was on regular follow-up. Since about a year, he started having worsening dyspnea, but no angina at that time. And because of that, he was advised to undergo a repeat CTPA with a CT coronary angiogram, but he refused, and he was just doing reasonably well on medical therapy. Now he presented to us with an acute coronary syndrome, which was troponin positive. Echo had a fairly good preserved LV function with hypokinesia of the inferior lateral wall, and he had pulmonary hypertension of about 50 millimeters of mercury on the 2D echo. So this is the angiogram. So as you can see that there is a significant lesion in the proximal circumflex. The LAD is totally occluded in the mid segment, and it is diffusely diseased. Along with that, there is significant chunk of calcium in the proximal and mid segment, and you have the RCA down which shows there are almost 3 lesions in the RCA with almost a corkscrew bend in the mid segment. So this was a patient who presented to us with an ACS but had triple vessel disease with severe calcific LED stenosis, which was 100% occlusion. And when we calculated the syntax for him, it turned out to be close to 40. So he was extremely high risk for PCI. CABG was definitely a better option. So we sent the patient to a cardiac surgeon for an opinion, and we got a CT pulmonary angiogram done again. So there was no evidence of any proximal embolism in him at present. There were signs of PH with dilatation of pulmonary arteries, and there was peripheral pruning of the vessel seen, which means that he definitely had some residual pulmonary hypertension. Now, in view of probably the lung issues and the residual pH that he went to two cardiac surgeons, but both of them said that this was and he was at a high risk for a procedural complication. They didn't refuse surgery, but they said it's going to be a high risk procedure, and so the patient was scared, and he came back for an opinion whether we can do a PCI. So after explaining everything to the patient, we decided to take him up for a staged angioplasty because there was too much to do in a single sitting for him. And whether we should use imaging was another thing that we thought probably because of significant chunk of calcium in the LED, maybe if we use imaging upfront, it might help us better. So we decided to try with an IVUS. So we started with the left system in the first sitting. So we started the circumflex. Now the problem is in the circumflex artery, we tried to pass an IVUS catheter, but the IVUS catheter would not pass. Actually, unfortunately, we had the older IVUS catheter from Volcano, the 40 megahertz one, and which was quite bulky. But it would just not negotiate the proximal bend here. And I mean, try what we just couldn't cross to the IVUS. So we thought, let us try passing a balloon. The 2.5 15 non-compliant balloon passed quite easily, and you can see there's hardly any waste here. And this is this is what we got after 2.5 millimeter balloon dilatation. So then we thought, okay, let us try passing the IVUS again, but unfortunately the IVUS still would not cross. So we said, let's forget IVUS. So let's see if we can now cross a stent, but even the stent would not cross here. So at this stage, so then we said, okay, let's go a little upsized, and we probably use a bigger balloon. So we went to a 2.75 non-compliant balloon. There is very hardly any waste there, and this is the result after a 2.75 non-compliant balloon. There is some haziness in the mid segment. Probably we caused the dissection with a higher sized balloon here. And so we thought, okay, let's now try to pass a stent. Even passing the stent was extremely difficult. We couldn't cross the stent, and finally we had to use a guidezilla. So unfortunately, I don't have the guidezilla shoot with me. We've not recorded it probably, but here you can see the guidezilla inside the guiding catheter after we crossed the stent. So this was a 2.75 26 millimeter ZES stent, which was crossed across the lesion. And it was deployed. There was still some residual stenosis there, so we used a 2.75 millimeter non-compliant balloon to 24 atmospheres, and the proximal part of the stent was dilated with a 3 millimeter non-compliant balloon to 16 atmospheres, and this is the result that we got. I'm sorry, the quality of this is a little. I just freeze. Yeah. So this is the result that we got. Now we still thought that there was something there in the mid segment. So we thought, now let us try passing the IVUS catheter to see if we can do something more there. But my IVUS catheter would not go. And because we've had these instances of foreshortening of the stents while trying to pass the IVUS catheter, and I was not very aggressive. I did not use the guidezilla to pass the IVUS catheter. I said, let's forget this, and let's go ahead and come back and look at this again at the end of the procedure. So then we went to the LED. So you can see the LED was a totally occluded vessel. So I crossed the LED with a microcatheter support and a Filder XTA guide wire. And after that, unfortunately, the microcatheter was getting stuck at this point. It just wouldn't go below that point. So we exchanged for a rotafloppy wire through the microcatheter, and then we burred the LED with a 1.25 millimeter burr at 180 RPM. And so we can see that that there is definitely a lot of RPM drop in the proximal to mid segment, which means that probably this vessel was severely calcified. So I mean yeah. So I mean, then we serially rotablated the entire the vessel right up to the mid segment, and this is the final polishing run. The total burning time was about 1 minute and 50 seconds here, and after that, this is the picture that we got. So I've kept some pictures and not videos because otherwise the presentation would be too long. So this here you can see that this is rotablated, and then we serially dilated this LED with a 2 and a 2.5 millimeter balloon. After dilating with the 2.5 millimeter balloon, we passed the IVUS catheter. We got some images, but unfortunately, the older 40 megahertz catheter. I mean, I actually honestly couldn't interpret anything in those images. It was really bad, and I mean, all I could make out was probably the distal vessel reference diameter was about 2.6 or so, and that's all. I really couldn't understand anything in it. So but there was definitely a lot of residual stenosis in the proximal segment. So we went ahead with the Flextome 2.75 into 10 millimeter balloon, and then we ended this procedure by two stents, 2.75 distal and a 3 millimeter proximal. In this also we can probably make out that there is still some residual in the mid segment. So the entire stent was post dilated with a 2.75 millimeter non-compliant balloon at high pressures. The proximal stent was post dilated with a 3 millimeter non-compliant balloon at high pressures, and the proximal segment of the proximal stent was post dilated with a 3.25 non-compliant balloon. So we have a 3.25, 3, and then a 2.75 at down. And this is the final result. So this is the LED shoot, and this is the circumflex. In fact, the haziness that was there in the circumflex also looks a little better here. I mean, I don't know whether I can freeze. So the haziness looks a little better here. Probably, I mean, doing the circumflex, we'd almost taken 45 minutes, and we gave a little additional heparin at that time. And then we went ahead. So this was the final shoot of the left, and then we took the patient out. This was almost an hour and a half long procedure, 110 cc of contrast in an elderly patient. So we kind of got him out at this point, and he did well. So I mean, we did an IVUS again. Now this is an approximate portion. So the distal vessel is here, the mid vessel just below that is here, and the proximal vessel is here. So this looks well rounded and well, but I don't know whether it is well approximated here or not, because I mean the image quality is quite bad.
Actually, you can calculate MSAs. Actually, MSAs are more important.
So the proximally, I think the MSA was about 9 or so. I actually don't remember, and unfortunately now I couldn't go back and retrieve the CD again. So I don't know the calculation of this vessel there. But the proximal was more than 9. That much I remember clearly. So this was the shoot at the end. So we got the patient back for a stage PCI to the right coronary artery after about 6 weeks. We took a left shoot. We can go through this just once more. The LED looks flowing and is pretty well. And even the circumflex looks much better today than what it did at that time. Still something is seen here, but I mean, he's done well for 6 weeks without any complications, without any symptoms. And so we just got him back. So because we had so much of problem in the left system, we directly decided to upfront go with an AR2 guiding catheter for the right, along with GuideZilla support. So this is the tortuous, you see the tortuosity of the RCA and multiple lesions, 1, 2, and 3. So we went with an AR2 guide, and we went upfront with the GuideZilla, and then we pre-dilated the lesion. We stented the distal with a 3.5 48 millimeter ES, and then we came back and we stented the proximal also with the 3.5 48 millimeter ES, and you can see it is just overlapped in the mid segment. Sorry, I go back. Yeah, so it's just overlapped here. And then we post dilated this with a 3.5 millimeter balloon, and the proximal part of the stent was post dilated with a 4 millimeter balloon. So this is the final result that we had in the right coronary artery. Thought this was acceptable, so we stopped the procedure here and got the patient out. So I mean, too many problems are encountered in this procedure for me. I mean, IVUS catheter, I just couldn't cross through the circumflex band. Probably if I had an OCT on table at that time, probably we could have used an OCT, and probably it's finer. I don't know whether it would have, yes.
How it would have changed your strategy, frankly speaking. If you had done IVUS, you would have, like if there was calcium, you would have used a rotablation.
Yeah, so my only contention is after the procedure, there was still some haziness seen in the circumflex, and I mean, because there is so much of calcium in the LED, probably there was some calcium spike or some calcium. I mean, some
How imaging would have changed your strategy in this
only
patient?
thing is to convert it to a rota. So do an imaging and probably just convert it to rota if there was significant chunk of calcium seen in the circ. I didn't want to go do a circ rota because on the angio I didn't think that there was so much calcium. That's the first thing, and the second thing is that I mean the balloon crossed so easily at that time. So I mean yeah, but yeah, if I had imaging and if it would have shown me a 270 more than 270-degree arc calcium or a deep-seated calcium, thickness more than 5 millimeters, then probably we could have thought of doing a rota up front in the circumference. That's the only thing I can think of. So there was difficulty passing stents in both the circ and RCA. Guidezilla definitely helped in this, and even I couldn't cross a microcatheter in the calcified LED. So rota was probably the way to go, which we did here. And I mean, and when we do such a complex procedure, the cost always comes into an issue. We use so much of material, the cost really goes haywire. But still, I mean, we need to use probably multiple balloons to optimize the stent, because even without imaging, if you have not co-dilated the stent properly, probably you would not have good long-term outcomes.
Amit,
Thank you.
I have a question. You had
Yes,
a
sir.
complex anatomy, very calcified, tortuous arteries, and
Yes.
you had a CTO of a fair-sized LED
Yes.
supplying live territory.
Yes.
On echo, there was no RWMA also in the LED territory.
No, sir.
Why
No.
did you not address the LED first?
Yes.
And
So
what would you have done had the LED CTO not been crossed?
yeah, so the thing is that I started trying. I mean, I started wiring the LED first, but every time I would try to wire the LED, somehow my wire would go into circumflex. I mean, I tried almost for 10 minutes. I don't know, I mean, what was really happening. And I mean, the LED CTO was a very short segment CTO. In the mid segment, I was I mean, fairly confident that I would probably be able to get through it. So my first contention was to start with the LED, do the road. So that is how I explained to the relatives that I'm going to do the LED first. If I'm successful for the LED, I'll come back to the circ, do the circ, get you out, and then come back to the right system. That is how I'd explain. But because my wire was probably going again and again into the circ, and I probably end up doing the circ first. Probably I should have still, tried a little harder and gone to the LED. That was the plan actually, to do the LED first. But probably circ turned out to be a much much more difficult thing in this than the LED actually for me.
Yeah,
The
I
circ.
agree that the proof of the pudding is in the eating. And finally, the pudding turned out fine. However, one would have been at a loss had you not been able to cross that
Yes, yes,
CT.
I agree, sir. I absolutely agree, because the plan was to start with the LED first. It's just because my wire kept on going into the circ,
Yeah.
probably I said, okay, let's do this. But yeah, I agree. I mean, I should have probably still stuck to my original plan and gone to the LED first.
Amit, really nice case. It was a chip case. 70-year-old with a PH with multi-vessel disease, one CTO involving, is really chip case. Requires a lot of planning. Now, 2 questions basically. So this patient was already on acetram. So what were the antiplatelets used?
No, so the patient was on acetrom for almost 4 to 5 years. He had actually stopped acetrom in the last 6 months on his own, and so he was not on any oral anticoagulant when we took him up for the case. So actually, I've given him ticagrelor and ecosprin, and we've not given him any acetrom at present. That's because of, I mean, I had a discussion with the chest physician also, and we discussed with a couple of colleagues, and we thought that probably he's not had a single episode of pulmonary embolism in the last 6 years. He's had only one episode, which was secondary to a DVT at that time. The cause we knew, and so whether we really should give him long-term anticoagulation at present, we were not sure. And because he had a troponin positive ACS, we decided to go away with the anticoag, which he had anyways stopped last 6 months. So we just given him ecosprin ticagrelor.
Second, Dr. Menon. Now, this is a unique situation which frequently occurs. We pass a wire, but microcatheter is not able to cross. So, what are the tips and tricks for putting a rota wire in such situations?
One is like what Amit did. You keep the microcatheter. I mean, you reach up to the tip of the lesion. See, your other wires already created a small channel. So without pushing the microcatheter in, just keep it at the tip of the lesion. Take this wire out, and immediately before it can sort of fall back, try and get a floppy wire in with a very small bend at the tip. so that it doesn't get into any false channels. And 99% of the times you should be able to wire the thing. Now, another technique that you can do is if it is wired, if you've already wired it with a stiff wire, and you don't want to you don't want to play around with it, and if suppose you don't have a microcatheter, you can bring the rota wire to the tip of the lesion, where the lesion, the other wire is crossing the lesion. Pull the wire back slowly, the initial wire slowly, and let this rota wire slip in. And in that, you can sort of manipulate the wire and get it across.
What is the burr size?
Yeah. Sir, one comment.
Yeah.
Yeah, sir. Whether this was a radial root circumflex?
Yeah.
Yes.
Radial.
So do you think femoral would have helped to cross the catheter, or it was not much of a difference between the two for this circumflex, the tortuous circumflex?
Actually, I think very rarely it makes a difference when you change sides, go from radial to femoral. Probably what I could have done was to increase the guide support. I don't know whether I could have gone with an Amplats. So you can directly go with an Amplats guide. But I was more sure about doing rota for the LED, and I didn't want to really use rota through an Amplats guide. So that's why I actually stuck to the 3.5 EBU extra support guide. Probably an Amplats guide might have made my life a little easier. So if this was a pure circumflex where I was not doing anything else, probably I would have gone with an Amplats guide. If I was not doing a rota. So my experience with rota through the Amplats is like nothing.
So what was the burr size used? 1.25?
1.25. Yes.
So is it advisable to use a 1.25 size when the uncrossable lesions are like this is like an uncrossable lesion with a microcatheter? Do you choose a 1.25 always?
So actually the thing is that we can go with an 1.5 also. The reason probably I chose the 1.25 was because in the filling, whatever distal LED that was filling, the LED size looked very small, probably not more than 2.5. I didn't really I didn't want to cause too much trauma there, so that's why I stuck to a 1.25. But probably whether I should have upgraded to a 1.5 after a 1.25 and done some more rota ablation is the question. I don't know whether I should have done that. I decided not to.
To add to Shantanu's point that he's trying to make is uncrossable lesions, the burr tends to get stuck more often.
Yes.
And the 1.25 tends to get stuck more often than the 1.5. Although, fortunately, we haven't had that experience too often. But maybe a 1.5 would have been...
what's your comment, Dr. Menon? Yeah, your vast experience of rota ablations.
I think what is done is right, because when you have a total occlusion, when you're burring through the lesion, it's always better to take a smaller burr, get a channel, and then upgrade it to a 1.5 burr, because a 1.25 doesn't do anything much. It just creates a channel there, and upgrade to 1.5, and then complete the procedure. The only problem happens is that if you are too aggressive with the burr, like you do a very fast pecking motion in these with a smaller burr, then the chance of the burr slipping through without cutting the lesion are very high, and then you will get stuck with a burr distally, because the backside of the burr, the proximal side, the distal end of the burr is a clean metallic stainless steel part, which will not cut and which will not come back. So when you're using a 1.25 in a smaller, in a total occlusion or in a very significant stenosis, go slowly. Go, but don't go with fast pecking motions. Let it stay there and drill its way through. Then the chances of the burr getting stuck are very low. Keep your ears open. You'll hear the noise of the burr slowing down. That is a sign that you come back and stop burring at that time.
Shantanu, there are a lot of questions from the audience.
That's the same question. Would rota help in circumflex, and what are the precautions for circumflex rota? Yeah.
The precaution for circumflex rota is, this is the only thing is you need to understand the anatomy of the circumflex. It takes two bends. It takes a posterior bend from the left main, and then it runs in the AV groove, and then it takes another bend to go and get another 90-degree bend to get into the obtuse margin. So when you're burying that vessel, you need to be a little careful that you take into account mentally those two bends when you're burying it. So go slow, be careful, and I mean otherwise it should be the angle was quite okay.
So I wanted to ask one question. The circumflex as a default, like in the LED or the other vessels, should we also go with the 1.5 bar only initially, or should we use a
No. Use a 1.5 bar, because in circumflex again you have, I mean, as long as you go slow, you can you just need to cut the lesion and get out.
So many times the wire bias also create problems in circumflex.
Yes.
Lepman and circumflex. Yeah.
And 1.25 bar will actually slip down the vessel much more faster without cutting the lesion. Because you need to realize that the circumflex is a very hyperactive area because of the running in the AV groove. So that itself propels the bird to a certain extent.
That's the main question. I think one more comment is there. IVUS use would have helped in deciding further dilatation of circumflex time. I think we covered that most of those parts. So very nice case, Amit. Very well done. It was really a great intervention. Now we go to the next case.
Excellent result. Finally.
Thank you so much.
We go to the next case by Dr. Sunil Wani. He's again senior interventional cardiologist attached to Kokilaben Ambani Hospital. He's been trained in Switzerland. And next is Sunil, please.
Actually, I have a case which is nearly similar like Amit's. Can you see my slides?
No.
Can you hear me and see my slides?
Yeah.
Now we can see your slide.
So this is a 61-year-old male, hypertensive diabetic, had LV dysfunction, EF 35%, regional wall in the LAD, had progressive dyspnea, PND, was advised an angiogram. The LAD had a calcific proximal CTO, a small OM 80% and diagonal 60%, and proximal plaque in the RCA. And the creatinine was pointed. The PET showed viability in the LAD territory. You can see the angiogram. So there are collaterals from the diagonal also. There's a blunt tip with calcification. And the right coronary, there's no septal, but you see a epicardial channel that fills the distal LAD, and you can see the extensive calcification in the LAD. So here the anatomy, there was a calcific mid-LAD around CTO around 20 millimeter, blunt proximal cap, distal cap not really well visualized, and then the antegrade collateral vein filling of the mid and distal LAD. The diagonal was filling the distal LAD. The RCA was tortuous with proximal plaques with epicardial connection to the distal LAD. The retrograde filling was visualized only in the distal. So here the scoring was 3. And preparation, would like to ask, I had not done a CT, but in a calcific CTO, here we discussed with the patient, the heart team, and we decided because of the calcific nature, the possibility of failure, and also complications involved. And I would ask the panel, would CT help me more in a calcific CTO? I had not done the CT though.
CT will definitely help you in visualizing the vessel and in charting out from which side, I mean, where is the possible entry of the LAD after the diagonal. So a CT would be helpful if you can do it, especially when you're seeing a blunt occlusion and you can't see the rest of the vessel very well.
But I think here the stump is seen after diagonal, no? There is a stump.
There is a little faint filling. Yeah. And so rotablation, microcatheters, and tonus was prepared, and a retrograde RG3 wire in case we feel we fail antigrade. Both femorals were punctured, 7 French XP 3.5, and retro shoots, we had the 6 French JR. Now, I use both femorals, but I think there's a lot of discussion between diradial and radiofemoral. I think more for my comfort, I think femorals are better. I don't know what the panel does.
It's an individual choice, I think. Yeah, you can go.
Yeah, I would go with both femorals. It's all individual experience.
Yeah. So the CT was attempted. This was some time back. So my wire escalation was like this. There was a Fielder XT fine cross, and CrossFit 100 I used to use quite a bit. This was some 4-year-old back, 4 year back, and CrossFit 200. And but now my thinking has changed a little. From the Fielder XT, I really go ahead with the Gaia 2. In this case, if the Gaia 2 also doesn't cross, then the Confianza Pro was available. And in a calcific CTO, if you have if your Gaia or a stiff wire sticks at the calcific segment, then you can use a parallel wire with a higher and higher tip load wire, or you can use a Crusade to cross. So I had kept all this ready, but my wire did cross the Gaia 2. Sorry.
Can you run the movies?
Yeah. So here, and the fine cross did not move much. It was stuck at the calcific segment. So
Sorry.
this is like what the earlier Amit presented. It's a similar situation, uncrossable calcific CTO. There was a large diagonal, as one can see here. So I anchored, I put a wire across and tried to pass the microcatheter. If I can cross the microcatheter, that would be a safer thing, that I have my rota wire distally, and then I can swap and do rotablation. And the other options that one has, I had already tonus, but the laser, obviously, I think Sir has experience. Dr. Menon would like to comment on that. When you have a calcific,
yeah, you can use a laser in these conditions. But again, if you can always get a wire across, do a rotation, that's always better.
I think what helps in such situation is improving your support. Basically, one is an anchor balloon technique. Second is you can use a guide zilla also to push the microcatheter. Sometimes it works.
Yeah. Okay. And so I didn't use. This is the turnpike catheter which the US guys use. This is the comparison of all the microcatheter Frenches that you have. So fine cross, as you can see on the right side, has a 1.8 French, and the other Corsair was other available catheter with me that time. Corsair in a calcific CTO could be a useful thing, that one could try and get the Corsair down, and then you could still safely cross your wire, the rota wire distally. But then I thought, instead of using the other catheter, I thought that I'll directly pass the rota wire, as we discussed in the
Sorry, can you hold on for a second? I'll just ask.
Yeah, sorry.
Yeah. There are 3 types of catheters which are available in India. Like one is Corsair, one is Fine Cross, and Caravel is now available. So among 3, what is your choice among 2 experts? What are your choices when you choose which microcatheter? Because we have discussed the previous thing, so we'll change the discussion to little different territory.
Absolutely.
I think in lesions where you need, you feel that the crossing is going to be a little difficult, we prefer to use the Caravel, because you can actually torque it through the vessel. It's got a tapered tip, and you can actually torque it through the vessel with torquing movements, and probably that gives you a little better pushability than the fine cross. So the fine cross is maybe a 0.1 French smaller than the Caravel. But the body of the Caravel is a little better in terms of support than the fine cross. We used to use the Corsair earlier, but we have had situations where the Corsair is a much more bulkier catheter, and we had issues with the tip at times.
So retro channels basically use Corsair or Caravel. Retro, if you are navigating through the retrograde channels.
Yes. Sure. For retrograde, Corsair is a good flexible catheter.
So.
And in a calcific CTO, I think Caravel is a little softer, I think they say. Is it? I just want to ask the panel.
Caravel gives less support, basically. And so sometimes you have to change Caravel if you are to not cross the lesion.
Absolutely. Yeah. So basically, what I did actually here is that I checked, which I think now everyone would not agree with me, that to be sure that I am in the true lumen, I checked through the microcatheter with the back bleed that whether I am in the lumen, and then I crossed the rota wire, and then at a 1.25 burr, we already discussed that. In the calcific CTO, I feel that one should go initially with the smaller size burr, as sir has already, Dr. Ajit Menon has already said that. Go with the smaller burr and then up titrate as you wish, and you go with the small pecking movements, and but you don't see really a good distal flow, and the artery doesn't look that good. So we post dilated with a 2.5 15 and stented with a 2.5 48 millimeter everolimus eluting stent. The balloon dilatation, I don't have those images. I'm sorry for that. So actually, this is the. It doesn't look looks like a suboptimal thing. So we got him back in 1 year. I will just show you the recheck shoots. He was better symptomatically, and I'll finish the key takeaways and I'll show the angiogram. Calcific.
Can you show the last picture?
Sorry.
Can you show the previous picture, last picture?
Yeah, sure.
Not that cranial, previous. Distal artery is not very well seen actually.
Distal artery is not well visualized. That I really.
After the procedure, because there was already retrograde flow. Maybe it will grow later. We can.
So the key takeaways, I have done an angiogram 1 year, which I'll show after the key takeaways. And the calcific CTOs are difficult lesion, important to study the angiogram. Good backup support is a must. Tonus rotablation is what was available, and rotablation is the way to go most of the time. And wire in the true lumen is a prerequisite, but there have been a lot of discussions that even if the wire crosses subintimally, you can still get away with rotablation. I would ask the panel on this part of it.
So, can you show the? You are going to show the?
Yeah, 1 second. I'll just.
Yeah, just show us that.
So that then we can go on discussion.
So there is diffuse disease down, but the artery is a little better. He's asymptomatic, so we left him alone, and he's doing fine. Nearly 4 years post. At least the failure episodes have reduced, and he continues to be on good medical management, and also an ARNI, which now 4 years back he didn't have.
So now we'll discuss little. There are some questions. Very nice case. Yeah, it was a nice case. Well done. So basically, can Corsair or Caravel used in calcified lesions? For that matter, Tornus even.
Sorry?
And that's a comment from Dr. Kirti Punamia.
Don't ever use a Corsair in calcified lesion. Caravel should be cautioned on torquing.
I fully agree with that.
Don't ever use
we
a
have had
Corsair
issues with the Corsair in calcific lesions. It gets stuck sometimes and becomes difficult to retrieve the Corsair catheter back. That's the way it is built.
Okay.
Yeah, your voice is mute, sir. You are on mute.
I agree. The Corsair is be very cautious when you're using it in calcific lesions where the tip can get stuck and you will have difficulty in retrieving it. Now, in this situation, one comment I had to make is you did the rotablator of the rotablation of the lesion, and after that you found that there was no good flow down the vessel. Two thoughts that come to mind. One is the vessel is badly diseased, or there's a flap somewhere which is causing the get compromised.
Yeah.
The second possibility is distal embolization of the calcific material into the distal vessels. When you're rotablating a total occlusion or a very long segment lesion with a lot of calcium, you can you can have situations where the muck can get embolized into the distal vessels, exactly like in a thrombus. And that's probably one of the reasons why you get no flow or slow flow after a rotablator. So
I
one
agree.
thing that you can try is take in a distal catheter, see the perfusion distally. Otherwise, give sodium adenosine, sodium nitroprusside, or other vasodilators distally, and see if the flow improves.
So we had done all that, and actually imaging would have also helped me to understand distally how bad I was at that particular time.
Yes.
If I agree.
Did you use a larger balloon for the proximal segment of the LED, or you just went with the 2.5 stent?
And I should have used I used a 3 actually, but still there is a little it's not completely expanded as you see in the LAO
Your
caudal.
proximal vessel is much larger, so again,
It's,
an
it's,
imaging
it's
would be a
really
good
a
idea to know
3.1. Yeah.
what's happening.
Yeah, and it's
And here, because there's no distal flow, possibly an IVUS would be a better option than this thing, because you may not get a good pullback on an OCT in such images.
So there is one more question. Like this patient had a large diagonal. Can that be used for anchor support? Yes, you can use. How to avoid injuries if you are using a large branch as a anchor support?
actually in this case I had used as I had mentioned that we had used as an anchor, tried to cross the microcatheter, and luckily we didn't have he was getting collateral flow. That one should also always look at the collateral flow, also the diagonal and the RCA. So it didn't affect much, but if that is the supplying artery, that can be worry. So you should always see the collateral flow also.
Actually, the trick is you use an anchor balloon same size at the side branch and don't inflate it at very high pressures. Basically, just 6 8 atmosphere is sufficient, right?
You always risk an injury when you use an anchor balloon. So the larger the area of supply of that vessel, be careful and expect the unexpected and be ready to tackle it.
So what size balloon should we use in anchor? Is there a guideline?
Depends on the size of the
Which
vessel.
size balloon?
Depends on the size of the vessel you are using.
Use a 1:1 balloon at low pressures.
Okay. So basically, in any CTO cases, nicely demonstrated as by Sunil, use of bilateral shoots, use of microcatheter, use of bias escalation strategy, and use of rotablation when required in uncortical regions. A nice case, Sunil. Next case is by Dr. Chetan Mambure. Chetan was a colleague in Bombay Hospital when I used to work. Now he is attached to Wockhardt Hospital. And over to you, Chetan.
Thank you, sir.
Shantanu, someone's mic is on and there's a lot of
I think
background noise.
some panel. You saw off now. Yeah. Okay.
Quiet.
Yeah. Okay, Chetan, you can share your screen.
Yes, I'm sharing. I hope my slides are visible now.
Yes.
Okay, now my case does not have very heavy duty interventional complexities, but it's more of a clinical presentation and clinical course in the hospital. It's a case of an acute pulmonary embolism with acute myocardial infarction. I'll start with the case summary. This is a 56-year-old male, hypertensive, obese, 102 kgs, non-diabetic, non-smoker, no family history. He was first admitted to our hospital on 21st of December 2019 with a left inguinal hernia. His pre-op investigations were all normal. ECG was normal, echo was normal. He underwent an uneventful laparoscopic repair and was discharged subsequently the next day. He came to me on the 1st of January 2020 with progressively increasing breathlessness since 1 week. When he came to my OPD, his pulse rate was 120, BP was 90/60, and ECG looked like S1 QTT3. There were no obvious ST elevations anywhere. So I took him for an echo right away, which showed a dilated RARV, moderate TR, PA pressure was around 65, with diastolic dysfunction. I suspected pulmonary embolism and sent him for a CT pulmonary angio, which confirmed that he had extensive pulmonary embolism, multiple filling defects in lobar, interlobar branches of LPA and RPA with extension into segmental branches. This was the ECG when he came to the OPD. So yeah, there was no significant ST elevation anywhere, but yeah, Q waves in 2-3 AVF and small S wave in one, and overall clinical picture looked like pulmonary embolism, which was established on CT pulmonary angio. So we admitted him, and this was the echo, dilated RARV. Poor echo quality is a little poor because of he is quite obese, 100 plus kgs. He had TR and PA pressure was high. So admitted him to the ICU, thrombolized him with tenecteplase around 7 o'clock. He was fine till 9 o'clock, and then he complained of severe chest pain. And this was the ECG at around 9 o'clock, which showed ST elevation in the anterolateral leads. Subsequent ECGs also were showing ST elevation MI in the anterior leads. Enzymes got elevated, and this was the echo which I did. So there were wall motion abnormalities in the LED territory. uh, Hemodynamically, he was stable. His blood pressure was fine. Though his EF has dropped, his PA pressure was better. RARV size had also reduced. I discussed with the relatives, counseled them because now he had become quite critical because of a pulmonary embolism issue, acute anterior wall MI. There were a lot of logistics issues regarding cost and consent, etc. And I couldn't take him for an intervention right away. So the middle pathway, I started him on a tyrofibin infusion. His pain settled in about 2 hours. He remained hemodynamically stable. In the meanwhile, we also got a lower limb venous Doppler study, which was suggestive of deep vein thrombosis, which was obviously the cause for his pulmonary embolism. Next day morning, this was his ECG. He evolved, the anterior wall MI had evolved Q waves in the anterior leads. And then we got him ready for an angiogram. So this was the angiogram. Circumflex was okay. Ramus, the large ramus, which was okay. LED was occluded right after the origin. You could see some small, faint flow in the distal LED, but nothing great. Spider view showed a better. We could see the stump there and a faint trickle of flow into the LED. And this was the right coronary artery, which was normal. So again, counseled the relatives and took him up for an angiogram. There were a lot of cost issues, and I did not have IVUS or OCT or imaging or any of that sort. But total occluded LED, we went ahead and opened it. I used my regular workhorse wire, which was a BMW. Managed to cross. The wire went after a long time, crossed after a long time with great difficulty. It went into the probably a diagonal, pre-dilated the lesion. Here the wire looks that it has crossed into the proper LED. At this point, I had some problem because the flow had stopped after the first diagonal. There was absolutely no flow. I dilated at this spot and a little lower down many times, but there was absolutely no flow and nothing was happening. The patient started to complain of chest pain. I was not sure what was happening, whether I was in the true lumen, what was down there. So I decided to take a microcatheter and do a small injection distally. So I found that I was in the LED. I took took the microcatheter a little back, again injected, and found out that there was a lesion again after that diagonal. After that, it became a little better. So things became a little clear. So I dilated it after the diagonals progressively till the proximal end. And then it was a little easier. Then I stented distally first. I took another stent, overlapped it with the first stent. This was after stenting. The LED was now visible. Patient continued to complain of chest pain. And this was after post dilatation. The final result. So LED had quite nicely opened up. Patient still complained of chest pain. You can see his hand across the chest. But he settled down after a few hours. I continued tyrofibin infusion for whatever it was worth. So there were two stents, distally 3.032 and proximally 4.044 drug-eluting stents. Shifted him to the ICU, and he settled down completely. And next day I shifted him to the ward. Did an echo, EFS 35, PA pressure had come down, and I also did a bubble study. Now I did a little literature search on these kind of presentations. Now it's extremely rare for a patient to present with pulmonary embolism and an acute MI at the same time, and most of the times it is quite fatal because of obviously two major thrombotic events. Some of the patients in these reports showed that they had a patent foramen ovale, which was confirmed on a transesophageal echo with contrast. And very few reports of, at least I found only 3 patients with reports of simultaneous PE and MI where there was no patent foramen ovale, and all had undergone prior surgery, and very few of them had survived. So the conclusion was that yes, you thrombolize these patients and follow it with a PCI. Again, the patient was not willing for a esophageal echo. I did a contrast study with transthoracic echo and could not find any evidence of a left to right shunt. Again, he was absolutely fine. I discharged him on the 6th of January. What medicines to give him again was an issue. Now he had pulmonary embolism plus an MI. So I discussed it with some of my seniors, and finally I discharged him aspirin 75, clopidogrel 75, and rivaroxaban 15 milligrams in addition to other medicines. He came for follow-up after 1 month, absolutely asymptomatic, pulse, blood pressure were normal, echo showed mild apical hypokinesia, no pulmonary hypertension. I repeated a CT pulmonary angiogram, which was normal.
There was no scar in the LV?
No, sir, the LV apex had recovered quite well, sir.
Very nice, Chetan. Some few comments. First thing is, like, did you do this contrast study while performing the Valsalva maneuver? Because
No,
ideally,
I did
what
not.
is recommended is a TE along with the Valsalva, you inject contrast. Then only you can demonstrate a patent to foramen ovale. Now, secondly,
TE with contrast echo with Valsalva. Okay.
Secondly,
Left will only then.
only then you can diagnose a patent foramen ovale.
Right to left shunt.
So in this patient, if I do find he'll be coming for follow-ups now.
Anyway, what is required is a long-term anticoagulation in this patient.
Okay, but if I do find a PFO, if I do as you suggested, then should that PFO be closed?
That's a controversial topic, but you can close. Yeah. If one life-threatening event is sufficient, I think. I feel.
Yeah. Okay.
Yeah. Secondly, why didn't you thrombolize patient when he had ST elevation? Because that would have helped on both the for myocardial infarction also and for pulmonary embolism also.
No, I thrombolized him. He came with a presentation of PE. I thrombolized him, and 2 hours later he developed an MI.
Okay.
This is called bad luck bhi kharab hai patient ki.
Because I had one similar patient. He had a stroke along with a pulmonary embolism, and we lysed and she recovered both. Actually, she was in time period for stroke, so we lysed the patient. She recovered from both. We did a TE with a Valsalva patent foramen ovale. We closed that patent foramen ovale. Actually, okay. She's followed almost 6 years now. She's doing fine. Now, coming to the case as such, now we have to discuss intervention. So I'll talk about thrombus management. Yeah, the thrombus management. He had a large thrombus burden. So, Dr. Menon, what is your strategy? Do you use a thrombo aspiration routinely or not routinely? Because there is a lot of confusion now. Now, Total and TASTE trial have debunked thrombo aspiration completely. So, in such situations, should we use should we be selective in using a thrombosuction catheter?
Honestly, irrespective of what those trials show, we go by the clinical situation, the clinical judgment, and in such a situation, as such a large vessel, I would definitely go with a thrombo aspiration initially. Now, it helps in 2 ways. One, of course, is to aspirate the thrombus, and the second, the thrombo aspiration catheter can be used to instill drugs distally, such as nitroprusside or adenosine, nitroglycerin, in some cases epinephrine, distally to improve the distal flow. We also use it to prime the distal circuit, distal band, distal vessel prior to stent deployment. Now, coming to this case specifically, you had after you opened up the proximal segment that you found that there was no flow beyond the diagonal. So in all probability, there was a significant amount of distal embolization, which is
Okay.
which stopped the flow beyond, and that is also seen in the fact that after you stented the vessel, the patient, though there was good flow in the LAD as such,
He continued to have pain.
the
Yeah.
patient continued to have chest pain. And if you see your angiogram, all the septals are occluded. There
Yes,
are no
sir.
septals seen.
The
Right.
septal
It's a bald, virtually bald mid and distal LAD.
Yeah.
Yes, sir.
So that's probably the reason why he had. I mean, he possibly had microembolization into all the smaller vessels,
Okay.
and that's the reason why he continued to have chest pain.
Okay.
You're lucky that nothing happened and he escaped with just a small infarct in the apical segment. Otherwise, this could have potentially had the chance to worsen the LV function over a period of time.
Okay.
That is
So
precisely
on
why.
table nitroprusside and all that I should have. Yeah.
Yeah, Dr. Kalra.
What I was saying, that's why I asked the question about the scar, because there is no diagonal or septal seen after the stent. So that is one, and that explains his pain also.
Right, sir.
That's already been brought out by Dr.
Yes, sir.
So what's the percentage of usage of thrombosuction catheter in your practice, Dr. Kalra?
I use a lot of when there is a large thrombus burden. As Dr. Menon already said, it's all on the table. If you see that there is a thrombus burden, I will use it. And when you have to use thrombus suction, I prefer the 7 French thrombuster rather than the 6 French.
That's what I was coming to. Do you find any difference between 6 French and 7 French?
Yes, a lot of difference. Yeah. In fact, there have been occasions when we have used the 6 French with no benefit, and I've stepped up to 7 French.
Actually, technique of thrombosuction also matters. While entering the thrombus, you should be on the suction. It should not be you go beyond and then start sucking. While entering the thrombus, and keep the suction on till your catheter is completely out. Then backbleed the catheter. And actually, I've always backbleed the catheter because sometimes the thrombus does lodge in guide and it comes back. If you are injecting,
not only that, when you're using 6 French catheters, radial procedures, and you're using a 6 French thrombus inside it, when you pull back the suction, the thrombus catheter, you always create some amount of vacuum, and air gets sucked into the catheter. So always remember that backbleed the catheter. Once you remove the suction catheter out, backbleed it, let the blood flow out, and then only start injecting. Otherwise, invariably what happens in a hurry, we take the catheter out, we want to see what's happened. Without backbleeding, we inject and we inject air into the system. That can be dangerous.
Also, actually,
So
sometimes you have big clots in the guiding catheter, and you see pressure dampening. So a lot of times we get scared and we inject, and then you will push the thrombus back inside and create a bigger mess. I think
you must backbleed always.
The technique of thrombosuction is also very important in such situation. Now, there is a question regarding now DAPT along with the anticoagulants. There is a question: like how should we go about this patient, like dual antiplatelet therapy along with a anticoagulation? Like what should be the dose of rivaroxaban in these patients?
So normally the dose of rivaroxaban with dual antiplatelet is 2.5 milligrams twice a day. But because this patient also had pulmonary embolism, that's why we started 15 milligrams once a day.
But that is a different indication. That's a compassed trial.
Yeah, that's a completely different indication.
Now this patient is for pulmonary embolism. We have to give a full dose, 15 milligrams.
Yes,
how long do you give a DAPT along with that? That's the question.
Yeah, that's even I wanted to discuss, because he will be coming for follow-up, and it's almost more than 6 months now. So how long do I continue with the anticoagulation?
Minimum 1 month of dual antiplatelets with anticoagulation, and then you have a choice depending on the patient subset whether you want to stop one of the antiplatelets and just give one anticoagulant and one antiplatelet.
Okay.
There are some people who say that you also give it up to 3 months and then you can shoot off just one antiplatelet. But I think that depends on the clinical subset. And coming to the same question that Shantanu said, it depends upon the dose of rivaroxaban depends upon what is the primary reason you're giving the rivaroxaban.
Okay.
If you're giving it as an anticoagulant because of a side condition, then you need to give the full dose.
Okay.
In today's times, one would do a COVID first. Because so much of thrombus burden, that would be one of the things one would keep in mind.
Ashish, you want to comment? Yeah.
Yes, sir. Up to date has got very nice review on this topic of patients requiring antiplatelets as well as anticoagulation. They have divided it into 4 groups basically. depending upon the thrombotic risk and bleeding risk. So this patient probably comes in high thrombotic, low bleeding risk category.
Yes.
So in this patient, even suggested we can combine ticagrelor with aspirin with apixaban for initial 2 to 3 months period, because there are 2 long stents and highly thrombotic. Plus, additionally, there is a pulmonary embolism and probably age and other risk factor. If you look at the bleeding risk is low. So in this, we can be little aggressive in the initial period and later on switch on to only single antiplatelet and anticoagulant. And probably this patient also requires workup for thrombotic state.
Yes.
Yeah.
Yeah.
So do you think? I mean,
But his his reason for embolism, like we found out post surgery, he had DVT and then later on he had pulmonary embolism.
Okay, so precipitating factor was there, right? Right.
Yeah.
Okay. So nice case, Chetan. It was a really nice clinical case, very rare presentation. So we go to the next case by Dr. Tanay Padgavkar. He's a young, upcoming, budding interventional cardiologist. Does a lot of complex interventions. He's attached to Somaya Hospital. And over to you, Tanay.
Good afternoon, everybody. I'll be talking about a bifurcation case today. I think, can you see my slides?
Not yet.
Not yet. No.
Share your screen.
Yeah, I've shared the screen.
Yeah, now it's coming. Okay. Yeah, done.
Yeah. So this is a case of a 65-year-old male patient. He was type 2 diabetic for over 5 years, hypertension and tobacco chewer for over 10 years. He presented with chest pain since 3 hours. The ECG showed anterior wall MI with raised troponins when he got admitted, diagnosed as an anterior wall MI and thrombolized with tenecteplase. His EF was around 40% with hypokinesia of the LAD territory. The blood work was normal and the patient was taken up for an angiography and SOS-plasty the next day. The angiography showed the left main appeared normal. The LAD had a plaque just beyond the ostium, the level of D1 with 2 tandem lesions of 80 and 90% beyond D1. The D1 was a good size long vessel with an osteoproximal 80% stenosis. Both had TIMI2 flow with a sort of Medina 011. LCX was a dominant vessel with distal segment stenosis. The OA branch also had an osteoproximal 90% stenosis. And the RCA was a non-dominant normal vessel. So this is the angiography in the iliocaudal view. The diagonal can be seen, which sees the ostium, and also the plaque which begins from just beyond the ostium in the LAD.
Sir, I'll just call you back after some time.
This is a epicranial view. We can see the lesions in the mid segment just beyond the LAD and just beyond the diagonal, and also the diseased ostium of the diagonal. So both the LAD and the D1 were wired. The Sion blue was introduced into the LAD, and BMW was put in the diagonal.
Tanay, can you stop here? Can you stop done for a minute?
Yes. Yeah.
So basically, there is a diagonal disease at ostium and lesion in the LAD beyond diagonal, right?
Yes, sir.
So I just want to ask Dr. Kalra, how do you approach?
I would do the LAD. Okay. I would probably leave the diagonal alone because that is just going to mess up the LAD.
You'll do the LAD beyond diagonal.
Yeah, beyond the diagonal. From this view, at least what I can make out on the screen.
So, Dr. Menon?
One second. I'll just run that. Yeah. See here, you have disease in the LAD even proximal to the diagonal. You have there's some disease in the proximal to the diagonal, and the diagonal ostium seems to be diseased. I think this is one situation where I would use an imaging to see what is the extent of disease in the LAD, see the extent of disease in the diagonal also, and then probably then decide the treatment protocol as to how I would address it. If the diagonal ostium is diseased, and it is and that is or if it's a very high risk plaque in the origin of the diagonal, probably I would go in with a two-stent strategy, plan it out and go it. If the diagonal lesion is not very significant, then I would go with the provisional treatment of the diagonal.
Yeah, I think imaging and plus will physiological studies help here, like FFR, IFR to the diagonal. LED is infarct hard to the diagonal physiological changes can be made out because this is a peri-infarct patient actually.
Yes, sir.
Yeah, FFR would be useful. However, there is no doubt that the diagonal ostium is diseased, but whether you need to treat it or not, that was the question.
The thing is, in the post-MI situation, no, there is like physiological studies always is a problem. In non-culprit vessels, there is no problem. It's been established, but in culprit vessels, the role of physiological studies is doubtful.
So the lesion starts just beyond the origin of the LED, isn't it?
Yeah, there's a lesion in the proximal LED after the origin also.
Yes.
That's why I said an imaging will help us chart where the lesion begins, where the lesion ends.
So Tanay, what was your strategy? What were you thinking?
So unfortunately, at this point when I did this almost 6 months back, there was no imaging available. That was out of question. I was not very comfortable with landing a stent in the plaque that is there around the diagonal, that is just before or after. I'm not very comfortable landing the stent there. So my decision was to basically go with stenting the LED from beyond the ostium till the mid segment. Because of the narrow angle and the diagonal ostium, I was quite worried about further plaque shift into the diagonal end. So the decision was taken to go with a dedicated two-stent strategy.
Okay, go ahead.
So the wires were introduced, Sion blue into the LED and BMW into the diagonal. There was some manipulation problem, so the wire was withdrawn, but the LED 2.5 millimeter balloon was then used for pre-dilatation of the LED lesion. After pre-dilating both the mid and the distal lesion, the stent was deployed. The stent unfortunately had not properly deployed in the mid segment of the stent. The same balloon was then pulled back for further pre-dilatation, and another round of pre-dilatation was done. Finally, two stents were used, and as we can see here in the diagonal and also in the LED, the diagonal stent was pulled back and positioned with almost 2 or 3 struts into the LED, and the diagonal stent was then deployed. The balloon in the diagonal was removed. The LED stent was then, I made sure that it had overlapped with the distal stent. There was a stent boost image, which I have not included here. And after that, the LED stent was also deployed. The LED has, the proximal one is a 2.75 by 32 millimeter stent.
You didn't take out the wire.
So after this, not yet, sir. Not recrossed the wire. So that wire has been trapped. A 2.5 millimeter NC balloon was used to post dilate the underinflated distal stent. After this, a 3 millimeter balloon was used for initial pot or initial post dilatation of the proximal segment of the stent. Then I recrossed with another wire, and 1.58 millimeter balloon was used for dilating the struts of the diagonal and the LED. And a 2.758 millimeter balloon has been kept in the LED. Then a 2.5 millimeter NC balloon was used to post dilate the ostium of the diagonal. This is the final kissing balloon that was given with a 2.5 NC in the diagonal and a 2.75 NC in the LED. And then final pot was done for the LED with a 3 by 10 millimeter NC balloon. So this is a image of the stent boost that was taken just before the final pot.
Okay.
And this was the final result. The LED stent was stented from just beyond the ostium. The patient was then shifted to the ICCU and continued on heparin DAPT. Other medications were optimized. His staged PTCA to LCX and OM was done after 3 days. He was discharged for 2 days, remained in follow-up, and we did a stress test for him just couple of, a month back. It was absolutely fine. No issues with the stress test.
Okay. Yeah, nice case. I want to ask Dr. Kalra.
Yeah.
We were on for two-stage strategy.
Yeah, if one has to do, if you have to do the diagonal, then you have to take a two-stent strategy because the diagonal is significant, and if you bring your LED stent proximal to the diagonal ostium, it is going to close. There's no doubt.
So, what is your choice of two-stent strategy? Which strategy you commonly use?
Maybe what he has done, something similar, or I would keep it as a provisional stenting, but in that case tap, but the angle was not really suitable for that. So two-stent strategy, the outset, something similar to what he has done. Only thing is, I wouldn't have kept the wire there in the diagonal and done a pot to the proximal segment because you have to be very confident of pulling the wire out.
Actually, when you are crushing the stent, you don't keep a wire because between two hard structures, like chances of wire tapping are very high.
Yeah.
So you put out
he was lucky to get it with it.
And DK crush. Dr. Menon, what you would have done?
See, this, like I said, for me, imaging would have played a role because it would have helped me determine what is the type of lesion there. If you the lesion in the diagonal looked significant, at least angiographically. So in all probability, mentally you're ready to treat the diagonal also. Yes, an FFR or an IFR would be a good idea, but logistically under our circumstances where cost is also a concern, and we cannot afford the patient to come back with a symptom in 3 months or 6 months time, and it's an acute situation. Probably yes, we go in with a justified two-stent strategy. Now, as far as the two-stent strategy is concerned, most of us tend to ignore the lesion in the origin of the diagonal. Suppose the LED lesion is soft, but the origin of the diagonal lesion is a fibrotic lesion, and you don't predilate it very well, or you don't open it up very well, or you don't get a good this thing. You always get a underdeployed stent or an underopened stent in the ostium of the diagonal, and that becomes a focus for a restenosis. And this is here the diagonal also is almost as large a vessel as the LED. So again, imaging will help us know what is the type of lesion there. So you can use additional balloons to open up the lesion very well before we deploy the stent. Coming to what strategy, probably a DK crush would be a good idea in this because the angle is not very great for a tap, as Dr. Kalra said. It has to be a DK crush or a mini crush technique in this. A mini crush technique is probably equally is good. Results are better with the DK crush. And again, like I said, preparing the bed in the diagonal also would be as important as preparing the bed in the LED when you go in with a pre-planned two-stent strategy.
Yeah. So
and one more thing, sorry, Tanay, in your case,
yes,
your pot balloon was sitting across the origin of the diagonal. So probably you could have done well with a shorter pot balloon, which could have deployed the stent in the absence of imaging. It could have helped you deploy the stent a little better in the proximal segment.
Yes. Secondly, will you like in mini crush, classical mini crush is with the stent, but now what we do is a step crush most of the time. We crush the stent with a balloon and then deploy the stent most of the time, which can be done through 6 French even. So he crushed the stent with a other stent. Is it a common practice to do that nowadays?
It's not a very common practice, but we still do it. We have been technically doing it for the last 20-25 years, and that is a technique that we have been following. And I think if like I said, if both the beds are well prepared and the stent is well deployed, we have not seen at least in our series and Dr. Matthews. I've been with Dr. Matthews for so many years. He's been doing it for donkey's years, And in his series of patients, we have not seen many restenotic lesions coming up at that site. That's basically the technique of doing it, and most importantly, preparing the bed before deploying the stent.
I thought his diagonal osteum was not very well prepared in this patient.
So actually,
There was a little
video I had
residual.
Maybe a
so
cutting.
that video. So that video actually I had not included, but I had pre-dilated with a 2.5 NC balloon for the diagonal osteum.
Like
just a thought. What about a drug-eluting balloon to the diagonal, Dr. Menon? What would you?
I am not very comfortable with the drug-eluting balloons in large vessels. We don't have any data to show that actually it actually works, and especially in such a large vessel which is supplying a reasonably large amount of myocardium. I think it's always better to have a stent in that vessel. I don't think we have any great data on drug-eluting balloons in such vessels, and what are the long-term results in this.
And I have also another thought. Would your strategy have been, see, this is a palming situation. Is it a primary angioplasty or at least a rescue angioplasty? And would there be a difference? Would you have followed
not really, sir. This was more like next day. The patient was relatively quite stable.
Pharmacoinvasive.
Okay, so you have the time to do two stents.
But in most AMI situations, you try to avoid two-stent strategies most of the time.
That's what I said initially.
In AMI, get away with the least amount of metal in the stent.
That's what I had initially when I said that I'll do only the LED and get out.
So this was a femoral 7 French, right?
Yes, sir. This was a femoral 7 French, and this was. Although on the table, this was next day, not a palmy situation.
Okay. So where did you cross your diagonal struts, proximally or distally?
Sir, distally, because I had actually, I think, pulled back this was 6 months back. I don't remember exactly, but if I'm not mistaken, I had pulled back the LED wire, then recrossed that into the diagonal and introduced a fresh wire into the
So in crush techniques, generally we try to go in the middle or proximally rather than
proximally rather than distally.
Yeah.
If you're not doing a stent in the diagonal, then you go distally.
Yeah.
If your plan
in
is
provisional, you go always distally. Yeah.
Chandra, with your permission, I'm just going to touch on one question of Dr. Prashant Kharche, that do you need to position the second stent, accurately position the second stent? You make sure that the second stent is at least distal to where you want to end the stent, because pulling back the stent is easier than pushing the stent back inside. So when you're deploying the side branch stent, make sure the main vessel stent is a little inside. So where you want to end the stent, so you can always pull back the stent after deploying the side branch.
That's why the crushing balloon helps. Like you take adequately, even crushing balloon's length has to be a little longer. It has to be, if you take a very small balloon, sometimes it slips proximally and then it's very difficult to pass that balloon further. So take an adequate size 15mm balloon or something like that, crush the stent, and then you can take the stent and position it very nicely. But here this thing also can be done like Tanay did and how Dr. Menon suggested. So
Sir, I had one question.
Yeah.
Suppose there's a LED D1 lesion and we go in with a single stent strategy, wired the diagonal, deployed the stent, done a pot, and yet the ostium of the diagonal is pinched. In this case, is it advisable to just dilate it with a balloon, a simultaneous balloon across the D1 ostium and the LED, and leave it at that, or do you have to stent it?
That is a hypothetical kind of situation. If you have to cross your stent across the diagonal ostium, then in this case, with this angle, probably you have to decide on a two-stent strategy.
Okay.
Right in the outset, because the angle is very unsuitable for a provisional strategy. You can
many times you get away with a kissing balloon. If there is just
with a kissing balloon,
with less black ball.
No, not in this case. I'm generally asking if something like that happens and after your
generally,
pot. After the
Generally,
pod,
if you
the
get a,
diagonal
if you
ostium still is pinched.
Yeah, it is done. It has been done. And you have got away with it also. We have got away with it.
Okay.
Kind of.
if the vessel is big, if you don't want to stent it, you do an FFR or an IFR on that vessel. If the FFR IFR is normal, leave the branch alone. Mostly nothing. I mean, most of the time nothing happens to it. If it is significant, a large area of a large vessel, large area of supply, you will have to probably go ahead and treat it. Now, the treatment option: use a balloon, open the struts up a little bit. You may get a decent result, but again, the chances are that you may cause injury to the ostium of the diagonal also if you use very high pressures.
Okay.
So I think,
Can I-
yeah, Amit,
No,
yeah.
just one- suppose if because the in this case the diagonal ostium was only involved, the distal diagonal was good. It's about 5-6 millimeters. We can always go with a provisional. So suppose if you go with a provisional strategy in this, and later on you need to go for a bailout strategy in this. I mean, there's a very little there's very small distance proximal to this. So probably tap and all might be difficult. So can we do a culotte in this? In that case, I'm just asking theoretically, because if you want to do a bailout, because the distal LED and the distal and the diagonal appears to be of almost similar size, so maybe you can use one of those newer stents theoretically, and probably do a culotte as a bailout, if not tap. Can we do that?
Again, sizing the vessel becomes very important. If you size the vessel, if you size both the vessels, and if your LED diagonal is as good as the LED, is as big as LED, or at least matching it to a certain extent, culotte is a very good technique for this for this sort of an angle of the LED diagonal.
But what about the long-term results? You will get a good acute result with a culotte. In this case, you are likely to get good. But I think long-term results, restenosis.
I don't think there's much of a. I mean, when you have a properly well deployed stent proximally in a large vessel at that point, I think the restenotic rates are well comparable to the other bifurcation techniques.
In provisional strategy, the rest to stenting, like if you want to stent a side branch, it can be either tap, it can be a culo, or it can be a inverse crush, what they call. Yeah, that also can be done. So there are many possibilities to get away. Like mostly is tap has been done. Rarely a culotte is done. Inverse crush is not done very commonly. So we had
the basic aim is to maintain the carina as much as possible, as much as possible, so that you don't create any major flow disturbances, and that is what precipitates the higher restenotic rate in those angles. So try and
narrow angle,
not to shift the carina too much.
Yeah, in narrow angles, if you do tap, the neocarina will be very longer, and that is a problem. So nice case, Tanay, and a nice demonstration of bifurcation. We had a very good session about complex, all types of complexities, from calcific CTOs, calcific lesions which required IVL, ablation, and a very interesting clinical scenario by Chetan. So very good session today. Any specific questions? I think most of the questions we have covered in the chat box. Thank you all. We can conclude the session here.
Yeah,
thank you very much, Shantanu, and thank you everyone.
Yeah,
very good variety of complexity. Thank you.
I think the basic takeaways are good guide support, choosing your catheters and armamentarium proper and adequately. Don't be shy of debulking when you have to get a good result. Imaging whenever it is possible, and with financial constraints, and of course, make sure that you give the patient the best benefit in terms of whatever the residual syntax score is, especially in multivessel diseases. And what Amit did in terms of the revascularization for all the three vessels was an excellent example of that.
Yeah.
No, I fully agree with Dr. Menon. These are the basics. Your strategy, well chalked out, your hardware decided prior to the procedure. Everything should be available, and excellent results can be obtained, as was shown by all the presenters.
Yeah, Thank you. We'll conclude the session here. Yeah.
Thank you, Shantanu. It was a really nice.
Thank you so much.
I think in pre-COVID times, at this time, one
Thank
would
you very
prepare
much,
for
sir.
a glass of beer. So let's all say cheers.
I think in Mumbai